introduce ourselves, everybody around the table, and then start?
Good morning. This is the first meeting of the Task Force on Affordable Accessible Healthcare. I'm Jennifer Carby from the Office of Legislative Counsel, and let's start by having the members introduce themselves, and then we will have you elect your co-chairs. Let's start down here.
Representative Van Donahue, I'm from Northfield, Berlin.
Lori Houghton, Essex Junction.
Representative Bill Lippert, representing Heinsberg.
Senator Ginny Lyons, representing Chittenden County.
Senator Keisha Ram Hinsdale, Chittenden County.
Great.
Nolan Langwell with the Joint Fiscal Office.
Great. Thank you and welcome to all of you. So the first item on our agenda is to elect your co-chairs. We are directed by the legislation to have House and Senate co-chairs and to select them at your first meeting. So I would entertain a nomination for the House co-chair.
I would like to nominate Representative Lippert as the chair of the Healthcare Committee. I think he's well suited.
Great. So there's a nomination of Representative Lippert for the House co-chair. Are there any other nominations for the House co-chair? Seeing none, we will vote on Representative Lippert as House co-chair. So all those in favor, please say aye.
Aye.
All those opposed, nay. The ayes have it, and Representative Lippert is your House co-chair. We will now elect the Senate co-chair. Are there any nominations?
I will take some liberties, being the only other senator here, but I am proud and privileged to nominate Senator Ginny Lyons, who also chairs health and welfare and really has a passion for a deep understanding of these issues as the Senate co-chair.
Great. So we've received nomination of Senator Ginny Lyons as Senate co-chair. Are there any other nominations for the Senate co-chair? Hearing none, we will vote. All those in favor of Senator Lyons for Senate co-chair, please say aye.
Aye.
All those opposed, nay. The ayes have it, and I will now turn it over to your co-chairs, Representative Lippert and Senator Lyons.
Good morning. I guess the first thing here is the charge to the committee, but before we do that, Bill, I thought maybe we would talk about how this meeting is being recorded and some of the technology. So currently we are looking at a screen that in this room. So anyone who is on Zoom will also be looking at the same screen that we're looking at. And we do have an audience. We also are joined by Jack Pitzer of NCSL, who is interested in the work of the task force.
Perhaps we should also say for those listening and those who are in the room, but I appreciate that everyone in the room is wearing masks. It's the latest guidance from the President Pro Tem of the Senate and the Speaker of the House that all members and staff are asked to wear masks due to the increased difficulties around the variant. And so thank you for doing that. I think if people can't hear, I just ask people to somehow indicate, because it's hard for me to tell. And my glasses are fogging up regularly, so I'm going to try to see what people are indicating as well. Again, thank you for wearing masks.
So, before we look at the charge, I think we all feel the weight of the work that we have before us. And as Jen Carby goes through the charge to the committee and other information, I think we're all very, very concerned about improving both access and affordability to health care. So as we're going through the charge, the world is so wide open and there's so much that we could look at. I think from our experiences, both in our districts, in the state, and in our separate committees, we understand the need to focus. So as we're going through the information, I think, and as we continue to do that over the next several meetings, think it's important for us to focus in on the things that we can do and how we can make improvements, close the gaps in our system, change the system in a way that will improve access and affordability. But the whole goal, I think, is not to be as expansive as possible, but rather to be as focused and as possible. That doesn't mean we aren't going to have some significant and large recommendations, but it does mean that we will have to be very specific in those recommendations. That's my perspective on this, and when we get into discussion, we can have that discussion later.
So I would welcome Jen Carby, who I guess we should say the obvious that Jen Carby, who is Deputy Chief Counsel from the Office of Legislative Counsel, is going to help assist this committee. Jen also works specifically with the Healthcare Committee and Health and Welfare Committee in the Senate. And Nolan Langwell is assisting us also from the Joint Fiscal Office. So appreciate both of you being here with us today. And we'll anticipate your assistance throughout the time of the task force. So thank you.
All right, would you like to review the charge?
I'd say.
Please.
All right, and I should have mentioned at the outset, you'll see it as we go through the language a bit, but the directive to the co-chairs is that you will alternate acting as chair at task force meetings. So you want to identify someone to take the lead today, or I'll let you determine how you want to
Do we have copies
interpret
of
that
that?
language. I think it may be on the web
I don't think it
page.
is. Looking at our, we don't have. it
Otherwise,
on
I can
our page
can send
yet,
it to
but maybe. it would be
Charlene. Yes, it
helpful
is
to
in
get that.
budget. It is sort of in the
Right.
just about middle of the budget bill, so it's it can be a little hard to find. But I'm happy to provide the language to Charlene to post and to make copies of.
Okay, if we can get copies of that, that'd be great.
I
Have it,
will get you the links.
all right, have it posted on our webpage, that'd be great.
All right, so in the budget bill from this past year, there was in section E 126B, a section creating this task force, the Task Force on Affordable Accessible Healthcare. It was created to explore opportunities to make healthcare more affordable for Vermont residents and employers. The membership is largely, as you see before you, there are 3 members of the House and 3 members of the Senate. We're obviously missing 1 member of the Senate at the moment. The powers and duties of the task force is directed to explore opportunities to make healthcare, including prescription drugs, more affordable for Vermont residents and employers, including identifying potential opportunities to leverage federal flexibility and financing and to expand existing public healthcare programs. And specifically in completing your work, you are first to keep in mind the principles for healthcare reform enacted in Act 48, which is Act 48 of the 2011 legislative session. Those provisions are also codified in 18 VSA section 9371. You are to identify the primary drivers of health insurance premium increases in Vermont, review the findings and recommendations from previous studies and analyses relating to the affordability of healthcare coverage in Vermont. And I'll just pause there to note that we do have, I think, posted on your committee page and also available in hard copy, a list of previous reports related to healthcare access and affordability in Vermont that I put together with assistance also from Nolan and from some other stakeholders, past and present employees of the state government who work in the healthcare arena. So if you look at it online, you can click on all of the links and they'll take you to those reports. So that should help you in reviewing the findings and recommendations from previous studies and analyses. You are also to determine actions that the state can take without federal assistance to address the unmet healthcare needs of Vermont residents and employers. You must analyze the long-term trends in out-of-pocket costs in Vermont, in individual and small group health insurance plans, and in large group health insurance plans, and identify opportunities to decrease healthcare disparities, especially those that have been highlighted by the COVID-19 pandemic and those that are attributable to a lack of access to affordable healthcare services. You also have the assistance available from a consultant. So the budget bill appropriated 125,000, I think I'll confirm with Nolan, 125,000 for a consultant to provide the task force technical and research assistance in carrying out its duties. And the charge says that the consultant's primary focus will be on monitoring and reviewing opportunities made available by the Biden administration to expand access to affordable health care through existing public health care programs or through emerging opportunities to address the unmet healthcare needs of Vermont residents and employers. And that consultant would remain available to committees of jurisdiction throughout the 2022 session as needed. You also have assistance from the Office of Legislative Operations, that's Charlene, Office of Legislative Counsel, it's my office, and the Joint Fiscal Office where Nolan comes from. You and your consultant are directed to brief the leadership of the House Healthcare Committee and the Senate Health and Welfare Committee by December 1st of this year on your preliminary findings, and then to present to the House Healthcare Committee and Senate Health and Welfare and Senate Finance your findings and recommendations by January 15th, 2022, regarding the most cost-effective ways to expand access to affordable health care for Vermonters without health insurance and those facing high health care costs, and the various options available to implement the recommendations. A couple other things to note. So you have selected your co-chairs. Your task force ceases to exist on January 15th. And you are entitled to per diem compensation and reimbursement for not more than 5 meetings. So that is the charge to this task force.
Could you at some point in the future add onto this list the Act 48 principles?
Sure, we can just post the Act 48.
That'd be great. Thank you.
Yes, sure. Post and we can print them out if that's helpful.
Thanks.
Yeah.
This is intended to be a serious question, but what are we not doing? Essentially, are there other efforts running parallel to ours that we should keep in mind to make sure that we stay in our lane and provide something that's valuable while not stepping on other efforts right now?
So there is also the Health Reform Oversight Committee, often referred to as HROC, and both of the co-chairs are also on that committee, so they are aware of what that one is doing. So I think you may need to just be mindful of who's pursuing what.
So just, and I think Representative Lippert will also weigh in on this one, but HROC is looking at the all-payer model and the waiver for continuation through utilizing the ACO. So those 2 areas are being evaluated and looked at, supported through HROC. This committee debated that in our committee in the Senate. And then I don't know, I think you probably did as well. And there was a discussion with leadership about how to work by allowing for this committee to look at the specific recommendations that we have before us, rather than get into the sort of the ongoing work with the ACO and the all-payer model. So we will, and I know there's a lot of interest in those 2 things, but we are not going to take the time with those. Our goal is to look at sort of the insurance, the prescriptions, the programs that are available to Vermonters and the cost of those, and how can we reduce those costs. HROC will be looking and evaluating, along with the Green Mountain Care Board, those other areas.
If I may add, thank you, Senator Lyons, and I thank you, Senator Hinsdale, for asking the question, because I think it is important. There's certainly a great deal of interest in all of these areas. At the last HROC meeting, in addition to what Senator Lyons has outlined, the Healthcare Reform Oversight Committee has also been taking up the issue of, do we have the appropriate regulatory structure for healthcare in Vermont? Do we have, is the Green Mountain Care Board in its current structure and its current responsibilities the appropriate structure at this point in time and looking into the future? So I would add that to an area that I do not see this task force addressing issues of healthcare regulatory structure in the state.
Maybe I should hold this for discussion, but it's related to the question that was raised.
Can I just ask, do we need to pull mics close to us for people to either hear on Zoom
Yeah.
or
That would be helpful.
I don't know how that.
I heard it was working well, but
Okay.
but you might want to.
We don't know how it's projecting.
Right.
So, yeah, I just wanted to reference, I recall a past presentation, I think by folks in the administration, that the current initiatives, all payer, all of that, are focused on cost containment and connected to quality, and are not focused on the access via affordability. So that's where I see that real distinction, that our focus is on access and affordability, which kind of aren't in that current model that HROC is digging into.
Right, I guess the intersection would be on ensuring that folks who need social service supports linked with their medical needs, that's available. And I think that's something we can include in our discussion, but going to look at the quality metric analysis that's going on is not within our.
Right. And as they reference it, cost containment indirectly ties to access and affordability, but it's not the direct purpose or focus.
Exactly. Okay, so would anyone like, for Jen, would it be too much to ask before we get into full-blown discussion, to have you go through what our work is exactly? So we've got 6 different, I guess, charges before us. So the question about having the principles for Act 48 in front of us is a good one. But maybe just go through those 6 things one more time, and then we'll remind ourselves about how many meetings we actually have to accomplish this.
Sure. So in addition to keeping those Act 48 principles in mind, the task force is to identify the primary drivers of health insurance premium increases in the state, to review the findings and recommendations of previous studies and analyses relating to affordability, determine actions the state can take without federal assistance to address the unmet healthcare needs of Vermonters, both residents and employers, analyze the long-term trends in out-of-pocket costs in Vermont in individual and small group health insurance plans and large group plans, and identify opportunities to decrease healthcare disparities, especially those highlighted by the pandemic and those attributable to a lack of access to affordable coverage in healthcare services. There's also sort of embedded in there in the work of the consultant to look at opportunities made available by the Biden administration, both to expand access through existing public healthcare programs and through emerging opportunities.
So as we're looking at 1 through 6, then when we get to discussion, we're going to have to decide how best this committee is going to handle that work. And then I guess I would ask Nolan, as you're going through that list, there is some data there that might either be in the reports that we have or that joint fiscal has in some way, or how do we access some of the costs that are affecting, going up, that are affecting her health insurance premium. So our goal, I think, is to gather some of the data that's embedded in each one of those charges.
And again, as Jen indicated, there really is a seventh, and it's implied, and perhaps because of the structure of how this came through the budget, et cetera, and it's here. And I think that really the looking at opportunities made available by the Biden administration is a very, from my point of view, is a very important piece of our charge as well. And that's, and the language suggests that the consultant's primary focus would be on that. And so I just wanted, even though we have 1 through 6, then this is not listed as part of 1 through 6. I think it's a key piece of what the chart is to this community as well, right? Our work.
And the other issue that is important to understand about the consultant is that consultant will be hired to support the committees of jurisdiction throughout the 2022 legislative session. That suggests to me that we may, as committees of jurisdiction, be meeting together in some way during that time to keep everything coordinated. But that's another discussion. Yes, ma'am.
Although, you know, those elements kind of outline the tasks, I think that the bottom line is the deliverable at the end, which is F2 in particular, is recommendations on the most cost-effective ways to expand access to affordable health care. So that's the real deliverable at the end.
Seems like a Herculean task, at least.
You want to call people or just kidding?
No, go ahead.
So I was just gonna add, specifically number 6,
Yeah.
both committees passed some legislation last session that I think reports will be coming up and activities are happening. It might be helpful to have, sorry, Jen, that added as well, thinking of the audio only DFR report, that one comes to mind. And I think there's maybe a couple others that would help us address the access.
So if I understand the question or the request, it's to identify which reports will be coming in that kind of dovetail with the work of this committee. Is that right?
That'd be great. Thank you, Jen.
Well,
And I would add to that, the thing that we hear back, although it's early for them, as the commission on
yes.
disparities in
Yes,
healthcare,
that's what I was.
which is just gathering, so we may not really get much, but to the extent that they're starting discussions.
We should work in coordination with
Yeah.
everyone.
So, and along those lines, I think we each get information coming into our emails every day about different possibilities for prescription drug, for example, prescription drug pricing savings, you know, through a prescription drug auction, the PBM auctions. I mean, there are all different possibilities that we may read about, and we're going to have to do some triage a little bit, maybe bring some of those articles in. I was going to send some out yesterday and I decided I'd wait. So there's a lot. There's such a huge amount going on right now.
I'm usually disappointed with the answers to questions like this, but do we have any information now about existing healthcare disparities and racial data, demographic, gender data? Do any of these reports tell us now what our healthcare disparities are on anything besides exposure and risk in COVID-19?
I'll defer to those who are more on the issues.
You know, we do have.
I would say absolutely.
Okay.
And we took, because we initiated in our committee extensive testimony that established the commission, the Disparities Commission. I don't think I have it quite exactly right, but the Department of Health actually has done a fair amount of work.
Okay.
And in terms of identifying disparities specific to Vermont, both around race, around sexual orientation, gender identity, around, I think, poverty, and and disabilities.
It's very extensive, and, you know, part of it began before COVID, and then some of it was added in.
But then indeed, there's been substantial additional specific information about the disparities that COVID has made very clear. Along with Ginny, I've been in the last several weeks, as many things come our direction because of our work in the legislature. I've been compiling I said, well, I'm just going to start compiling a list of articles, but whether I've had the chance to read them now, I will read them, perhaps share a number of them, as you said. And one of them, just in the last day, was specific around health disparities nationally, which I think is a different context than Vermont, but I think it frames some of that issue as well. But we do have Vermont information.
Yeah, that's a big area.
Yeah.
It's a huge area. Well, some of it's social and some of it's biologic. So the discriminating will become very important to us.
So none of it starts to try and articulate where it might be related to a lack of access to affordable healthcare.
I don't know.
Okay.
Yeah, we'll have to sort that out. Yeah, that's good. Very good question. You know, before we continue into our discussion, I'm wondering, is this time, Nolan, to get an update on the consultant, or do you want to hold up on that?
Up to you, I can talk briefly a little bit about it.
Okay.
Yeah.
Do you mind talking into the mic?
Sure, I want me to come over there or over here?
Sure, let's do that, and then we'll move
That'd be
into
very great.
discussion.
For the record, Nolan Langwell, the Joint Fiscal Office, we have put out an RF, a request for consultant services. We got several responses from very high qualified organizations and consultant organizations. So I feel pretty, Tony, can I have those? Sorry, thank you. From very high qualified organizations. So we feel very fortunate to have such good responses. We've done some interviews and we're gonna be reconvening our group soon. Think about the next steps, but we want to make a decision shortly and hopefully have the consultant in place definitely before the next meeting. And that's really all I can share at the moment.
It might be helpful just to be as explicit for those who are listening, that's the Joint Fiscal Office who is interviewing and hiring the consultant.
Correct.
It's not this task force, and it's not the legislature in general, but it's the Joint Fiscal Office that's been charged with that task.
Correct. And as highlighted in the final product, and second task force along with the consultant that will be providing the report. And also as Representative Lippert talked, the primary focus of that would be the new number 7, finding opportunities, but it's also to support the other work in the first 6 as well. So, and hopefully after today's meeting, we will have some more guidance from this group to help inform our decision for who of the organizations we talked to would be the best fit based on the conversations you are having today.
That's terrific, and thank you for that. But one question, I guess, is as we're going through 1 through 6, which really fall on our shoulders, not that number 7 doesn't. But as you're looking at this, and you're also looking at the reports that we have available to us, maybe it would be helpful to know where you see a need to collect additional data. So do we have a specific report, for example, on identifying primary drivers of health insurance premium increases? And if we don't, then maybe some thoughts to help us, and we're going to have to do this ourselves, about how do we collect that data?
Yeah.
So that kind of question. I'm just looking at that one because it's number 2. It's on the first page. It's not because it's the only one.
Yeah, and that'll be part of the process, is helping you identify, as Senator Hinsdale talked about, is helping you get the information you have available, or identifying the information that's available now, determining where those gaps are to help inform your work.
Okay,
And some of your recommendations might be to get better information in certain areas.
Okay,
We're passing out this is a presentation printed out that Jen did to help you inform the Act 48 principles. You have them at your fingertips.
What a quick turnaround on that.
Well, yeah, teamwork.
okay, wow, this is helpful. All right, any questions, any other questions for Nolan regarding consultant or other?
Can I just ask, maybe it's not fair to ask at this point, if it's not, please say so. You said consultant, the hope and the intent is something available by the next meeting, we'll establish when that is at some point. But so have those who are applying indicated that they're available to do that?
I think that it's implicit that the given amount of time that you have to do the work, that they know, or assume that they know from our conversations, that they will be hitting the ground running, because you have such a short timeline to do your work.
Great.
So
Thank you.
most of the ones we talk to get that.
Anything else? Question for actually probably for the committee. Our next, the item on the agenda that we've been moving into is discussion of goals and priorities. And before I ask, do we want to go through Act 48 principles, which we may want to do with Jen while she's here? I guess the question for the committee is how we approach each of these specific tasks before us. We have a number of reports that relate to the individual goals, but I think I kind of like to hear from each member of the task force what your thinking is and what you think we might derive from the work that we do, where your focus might be. So can we do that?
Yes, I agree. I'd like to give us each a chance to talk, even if it's broadly, and then have us come back, focus, as you indicated. So I think that'll give us a general, this is, I think for people to understand, this is the first opportunity we've had as a task force to sit down together. We have not been meeting absent formal meetings. We have not had the opportunity to talk to each other. Although I do acknowledge that Virginia and I put some time into getting an initial agenda established anticipation, but we haven't had this opportunity for ourselves. So this, I think it'd be good for each of us to have a chance to share some thinking.
Anybody want to start? I mean, I'm going to hold off.
I'll start.
Okay.
So I think for me, obviously, this is a very broad topic, and Senator Lyons, as you said early on, we do need focus, or nothing will come out of this. I'm happy to hear that HROC is looking at the all-payer model and the waiver, and that we can truly focus on affordable and accessible healthcare. I think one of the things would be good to review or maybe establish, I'm not sure if it's been established, is what is affordable and accessible? How is that defined? What is our definition as a state? Is there one? What is our definition as a task force? I think to the discussion earlier about what information we have on disparities already, we just have gone through this pandemic, or still in one. And I think we have learned a lot from that can help inform our work here. We had a lot of regulations relaxed. We had telehealth relaxed. How has that helped with accessibility? Can we get some folks in to talk to us about that? And and look at that data to really inform our work and help us immediately start thinking outside the box, because that's what we've been doing for the last 18 months.
That's all I have.
Good, thank you. Good. Ann or Keisha? Senator Hinsdale, Representative Donahue?
Can be informal. I'm happy to, I mean, I think Representative Houghton's on healthcare as
Yes.
a committee, right? So I think I'm the only one who is not on a healthcare committee. So I wanted to wait for someone who was on to speak, because it makes me feel better that someone on the committee is asking what is affordable. You know, for me, a big question is what the definition is of being underinsured and how many Vermonters and Vermont families are experiencing being underinsured. Because that's what I continue to hear about. It's just, it's one thing to have healthcare, it's another to be able to afford to access it. So, you know, really wanting to meet that goal of understanding what the cost experience is of Vermont families and small businesses, and what we can do to close those gaps. And, you know, in general, I just think Vermonters deserve a North Star again around what we plan to do to advance healthcare affordability and general healthcare reform. You know, I was there for Act 48. That was 10 years ago now. You know, I remember it felt like with the healthcare exchange rollout, Vermonters and Americans lost faith a little bit that government could, you know, manage a large enterprise like their access to healthcare and health insurance. The pandemic, I think, has started to reverse that perspective from Vermonters and Americans, that they understand the need to have shared principles and shared access to healthcare, and that makes everyone better off. And so I think we're approaching this in a really good moment to re-envision that North Star and be able to talk to a very amenable, in my view, administration at the federal level about what it looks like for us to be a laboratory of access again. And so I'm just really excited about the timeliness of our work.
So just to clarify, you are agreeing with Representative Houghton that we should be at least looking at how to identify, how to define affordable and accessible. And then you've also brought up underinsured.
Yes, you know, to me that feels like affordable housing, where we know what it means to spend too much of your income on housing.
Yeah.
I have that number easy to recall, but I don't have the number for what it means to spend too much money on healthcare as a family.
And that becomes a really interesting conversation, broken down into long-term care, prescription drugs,
Right.
et cetera, et cetera. So, yeah, good. Timely. Okay.
Piece of paper so that you can.
Thank you.
Oh, good. We have it consolidated.
So,
Oh, that's great.
Thank you. Go ahead, Representative.
I've been trying to kind of sort out the critical big picture aspects that we want to hold to with what Madam Co-Chair said in the beginning about really needing to end up with some very specific recommendations about here's some things that we can do, you know, without federal change, with potentially federal change, and in terms of disparities. And it's kind of a mega task. So I was trying to just sort of, okay, we've got 4 more meetings. What would we need to achieve in each of those to get there? And because initially I was thinking, well, each of these numbers, we come back and analyze these issues in the first one and then these in the second. I was like, oh no, we're out of time already. So it really seems that 3 of the items, number 2, 3, and 5, are really about identifying and analyzing what's current and what's happening. And that we really should be trying to do that at the second meeting, which sort of plays into brainstorming on what sort of priorities might come to the forefront from seeing what we know from all of the existing data and what out-of-pocket trends are and so forth. And then that would give us the third meetings on trying to identify those actions and opportunities, which are kind of 4, 6, and 7. The possible actions with or without the federal government and disparities. Because then by the fourth meeting, we really need to be at a point of preliminary findings, which are due in by December 1st. So that's where I think that meeting would be really honing down to what our priorities are in terms of viable actions and recommendations for direct steps. And then our last one on finalizing a report and those recommendations. So I think we've got to start with pulling together what we do already know and how that defines what we think the priorities are for making progress on affordability and accessibility. That's sort of the next step. And then from there, looking at what are the things we can do something about and that we end up prioritizing as the things that would make the most impact on the big picture.
So what I'm hearing you say, and I think I agree with that, and you've done a nice job of setting up the next several meetings that we can, thank you very much. But when you're looking at numbers 2, 3, and 5, that would be culling data, pulling out information, that's something I think that was kind of the question I was asking of Nolan earlier, and probably Jen as well, and then us, look from our experiences. So I think we're going to, and perhaps the consultant can give us some help in that area as well.
And we might want there might be some witnesses in terms
And,
of
yep.
updated information at that stage.
That was the next step, and then pulling in witnesses to help us with the data that we have or improving that data and analysis. The first task is to go through and see what's there. Then after we have that, I don't know how we do this all and make it happen before the next meeting. We can certainly invite people in to reflect on the work that's there in front of us and to add information. There will be an iterative process. We'll have to do that. Yeah, okay.
And probably the biggest homework piece for us would be preparing for that second meeting in terms of looking at some of that this great list of all of the work that's been done.
Yes, and so that, Nolan or Jen, is there, I don't remember the list. I've gone through it, and I know I've read many of the reports that are there, but is there underinsured information within that list? I know we've looked at that in the past. I know in Finance Committee, we spent a lot of time on it.
The only place that has data on the underinsured is the Vermont Household Health Insurance Survey. Right. And that's from most recent, I believe, was 2018.
The report was 2018, the data may be 2017.
Yeah,
So
but they are
it's
actually
not current.
not current, but they will be conducting it soon.
Okay,
But it won't be in time for this.
okay.
Right, I was gonna bring that forward just to say, and to, if anybody else might pick up on the fact that we have, I think it's important for us to understand and acknowledge that we have other processes underway. This is a continuing process. This is not something where this is the first time or the last time we're going to be looking at this issue. I see this as a special opportunity. This is a special opportunity, and I think some ways, Senator Hindo, you framed it well as saying that this is a point in time where there's an opportunity to stop. Look, we're in the midst of. I think many of us understand that where we would like to, where we want to end up. We want to end up with affordable, accessible healthcare, whether that's insurance and access to actual healthcare for all Vermonters. We understand that we are not there at this point in time, but we have been, I think it's also important for us to understand and acknowledge what we have been doing. And we have a new household insurance survey that's going to be underway. And I think I had asked Nolan a bit about that. And I think it might be useful if you could, I don't know if you have it in front of you, but you could remind us. But unfortunately, the outcome and the analysis of that won't be ready for this task force, but it'll be available for us as we continue this work when we're back in session. This work, in my view, this task force is an opportunity to take more time than we have in the ordinary flow of our legislative work to really focus on affordable, accessible healthcare. With the understanding that from my point of view, the question that I have is what are the key things that we can do that are achievable that moves us toward the ultimate North Star, the goal of having affordable, accessible healthcare for all Vermonters. And so I'm particularly interested in, I want to focus, but I don't want us to preemptively lose the opportunity to look maybe more broadly than we have sometimes the opportunity to do. We have opportunities, people submit bills, and sometimes we're reactive to legislative proposals that have come forward or advocacy group proposals. And I want to just acknowledge Senator Lyons took the initiative to be in touch with the NCSL, National Council State Legislatures. And I think Jack Pitzer is on listening in along with perhaps another colleague. And I've had the opportunity as the chair of this healthcare committee to be part of several of their national Zoom meetings and in-person meetings. And I jokingly said, but seriously said, we in Vermont sometimes forget that there's things we can learn from other states. We have a way of thinking that what we're doing, and sometimes the feedback we get is like, what you're doing is very important and very special, but there is a lot to be learned from others. And I'm just going to name a couple specifics that Jenny, you've mentioned before, and I think we're all aware of, but one which I had not been aware of. For instance, the global budgeting, global hospital budgets in Maryland, which is an issue which has come forward. I'm not suggesting that be the focus. I just use this as an illustrative example of where NCSL may be also a resource to us in understanding what are some initiatives in other states that have gone well or that they've learned from. I recently, in a meeting with NCSL, learned that I believe New Mexico has eliminated all copays for mental health access. And so that it made mental health treatment more accessible to all citizens of their state. Now, that was the first I'd heard that particular initiative had been taken. Again, I'm not listing that as something we should absolutely do, but it's an example, learning from what's happening in other jurisdictions that we might use, that might be used to inspire us in our work as we think about specifics and looking ahead. And while I'm on that, I'll say the area of mental health is of serious concern. And I'll reiterate for all those who are, and I'm speaking to the choir here, but mental health is healthcare. We cannot think about healthcare without thinking about mental health care and substance use disorders. So somehow we too often silo these issues for ourselves. Now, I'll just say one or two more things and then stop. But for me, another piece that I would like to suggest that we hear about at our next meeting, and that is there are already federal initiatives that have taken place. There's a huge infusion of federal dollars into making premiums more affordable. It's happening as we speak. The closing of the special period was August 15th. And I know that DEVA is looking at, I have made a request, could they analyze for us what has been the impact for Vermont and specifically for Vermonters on the reduction in premiums, making it more affordable and accessible because of the reduction in costs. And again, yesterday I heard at a federal level that they based on the American Rescue Plan, 2.5 million additional folks have signed up. I don't know how many folks have signed up in Vermont or changed plans, and that nationally the reduction in premiums was $2,400 a year. And for those who now can get access because they don't qualify for Medicaid, but they qualify for these premiums and in fact have zero premiums or very, very low premiums. I think it's very important for us to understand what that initiative's impact is on Vermont. I'd like to suggest that we ask Eva to come in and present that to us at our next meeting. And I'm very interested in what opportunities may lie in front of us with other federal initiatives as well. So these are broad pieces, but I think it's important for us to keep them in mind as we make our plans for what this task force can learn from and focus on.
Okay,
Can I just add one thing on to-
can you want to add?
Can I
one?
add one thing on what you just said and then I jump on?
Yes.
I think it's also important for us to remember on this task force and those who are watching, the recommendations that we will make, who we will actually be able to help. Because as we all know, in healthcare, there are plans we at the state level can't do anything with. So as we move forward, I think it's just important for us to put that on the table, make sure those that are watching understand truly who in Vermont we can help, who we can impact.
That is a very good question, that we probably should keep in mind the whole time.
It's not information many people
Yeah.
have at their understanding necessarily, that there are some limits to what the legislature can do to health insurance.
And along those lines, and of course, when things impact us, that sometimes raises them to the forefront in a way they haven't before, but we have some real cliffs that people hit when they become eligible for Medicare and therefore lose other pieces. One of the interesting examples is the Rescue Act addressed COBRA payments for folks who might have lost unemployment. That did not go to COBRA for employers who were offering, for instance, Medigap coverage. So it only helped people on standard insurance. And likewise, some of the subsidies that are available are not available for people who have Medicare or are at much lower thresholds. And so in terms of the state components of support, we sometimes don't look at those and how they are equivalent or actually not equivalent to what we do for people who are not on Medicare.
So those are really good distinctions that we should ask the consultant to help sort out. And then we can know how that relates to our Vermont businesses and folks who have insurance coverage. I mean, that actually probably goes beyond what Nolan, you would want to do at this point. I think it would be more of what the consultant can do to help understand the federal, just what she said.
Yeah, Representative.
Well,
Just take that one more time.
looking at the distinctions and disparities in terms of supports that either the state or federal government gives to people when they become eligible and go on Medicare, there are sometimes cliffs there. I know one of the folks at what is it, not AARP, but who provide the counseling for people who are making Medicare choices. And when I met with them and they found out I was a legislator, they were right away waving this flag about a significant disparity for low-income folks when they make that transition, that the subsidies they can get are much less than what they would have gotten before they turned 65.
So it also raises the question about what our healthcare advocates office might be able to provide. They deal with this all the time. And perhaps our insurance company. So we have a number of folks we can hear from who will help clarify those questions, the answers to the questions. So I'll just weigh in a little bit. Everything that everyone has said is so critical and important. I would like to say that a couple of years ago, I can't remember when now, it was in the middle of COVID, so must have been a year ago. I did meet with a consultant who, a person who had been on the financial review board for Maryland and did talk about global hospital global budgeting and what that looked like. And would be a slightly different regulatory system. So that's something that perhaps HROC will be looking at. So the global budget piece, but the question, it does raise the question about where are the costs embedded, and hospitals, as we know, do have a very high cost and high budgets, and people do look at that money as opportunity, but we also need to understand the sustainability of hospitals is critically important. So there is a report that is going to be done by the hospitals that will be coming in sometime in the fall on hospital financial sustainability. And how that informs us will be interesting. If we start to look at segments of the healthcare system and think about hospitals and their role, then we think also about primary care. And so for to that little place, I will say that keeping in mind all the different sectors and support services that we have, and one of the goals that I think is really critically important is to link people between primary care, chronic care, specialty care, and then social services to have a continuity, a system of continuity. Maybe there's something that can be done that would allow for an improved care management for folks as they go through that system. But and that's a tough one, I think. For me, I know that there's been a lot of work done on the costs of primary care. And Bill mentioned, Representative Lippert mentioned eliminating out-of-pocket for mental health. But we also know that if we don't have primary care available, those prevention services available to folks will avoid going because it might cost something. So if we had some access to primary care without out-of-pocket, I'd like to know what the cost of that is. I know there was a study done a couple of years ago on that, and we did look at the cost of primary care overall. For me, that's a really good stepping stone into improved access and affordability for folks. And then I think about we cannot ignore, we always think about who we are and the citizens we represent and how to ensure that they have access. There's no question that that's not the primary goal, access and affordability. But we also know that there are some real struggling providers out there, particularly in the primary care world. So that's something we cannot forget. And how can we sustain the rural primary care services that are so critical? And then I also think about folks who are chronic illnesses. You know, perhaps they're supported through our Blueprint program. But I think about the people on the edge. We've got people who are on the edge of disability or may qualify or not qualify for disabilities. And some of those folks are stuck. They get stuck in their jobs because if they get a raise, they're off Medicaid. and they can't afford the next step. So knowing what those cliffs are, I think are important, and how do we help people? I had an idea, okay, here's an idea. Just throw it there. If someone is classified as being able to work 20 hours a week and can't work any more than 20 hours a week, then maybe it's okay to give them a raise. And maybe it's okay to keep them on Medicaid. I mean, maybe there's some things we can do to help people that are stuck in those situations. I think about those people a lot. Okay, so it just, there's a lot that we can do, but I'd kind of like us to think a little bit about how we can improve access to prevention services, primary care, and care management through the system. And that would go for folks with substance use disorder, mental health issues that are so been exacerbated by COVID, as well as folks with disabilities. So I think that those are some of the foci that I can see as being important. And then that raises the issue for me of alignment and how our public and private insurance coverage is aligned, whether it's through our Affordable Care Act, ACA system, or whether it is our Medicaid and our private insurance system for our small business. We get into all the federal stuff, but so the alignment of where are the gaps, I guess, question. Okay, I'm sorry, that probably wasn't as focused as it could have been, but I would add that, Bill brought up NCSL. And I did go to a webinar. I've been to a couple of different things beside the global budgeting, but also went to the webinar that NCSL provided, which was very good because they were looking at how to improve access, how to improve cost, change the cost metric. And the concept was, well, you can't do the big thing, but there are a lot of smaller things that we can do. So I think that maybe looking at other states through NCSL, and I did ask Jack Pitzer and his team to, they were very happy to listen in today, and I'm hoping that what we're talking about will inspire them to work with us. Because they do have access to other states. That's not the only organization. I know NASHP also does some good work, and I know that particularly in prescription drugs and CSG, but I think NCSL has stepped up to the plate. Well, I think maybe we can reap some benefit from that. That's all I wanted to say at this point. Go ahead.
I think I forgot sort of the elephant in the room is the workforce.
Oh,
Because no matter how affordable we make it, if there's no providers, there's no access.
very good.
And I think even in terms of like the hospitals presenting their budget this year are identifying the challenges in recruiting for the workforce as a plus driver. My local hospital CEO talked about they can't even get travelers to fill positions because there's no housing for them. So we loop
Right.
around to another issue. They can't, they're asking staff, do you have a spare bedroom? So that they can get coverage for key positions.
Good point, Representative Donahue.
And a couple people brought up benefit cliffs. This is definitely outside probably our realm, maybe something the consultant can help with someday, but we talk about the benefit cliffs just for healthcare, but look at all the other social services we know impact people's healthcare. And what are the benefit cliffs are different. So you have 3 squares. That might drop off. That could affect your healthcare. It's not just when you fall off Medicaid. That's a really broad topic, but I think it is something that as a state we need to look at and start aligning all of these services and where they fall and look at the global picture of a person's access.
Yeah, exactly. I mean, to, on a very simplistic level, one insurance program may allow for 10 visits to your substance use disorder counselor, and Medicaid might allow for 25, so that kind of alignment, I think, in terms of clinical quality and outcomes become important. Anyway, are we making any progress?
I want to remind us of one of our co-chairs call to stay broad.
Jen, do you think that there's any focus that you can identify in all of the discussion that's going on here?
I think that's really a question for the task force. I mean, I think you're hitting on a lot of the ongoing issues in the healthcare system. And I think you need to figure out whether there's a particular angle you want to approach affordability and accessibility from. I think that, if you take on too much, you're likely not going to accomplish.
Right. Yeah, and the one big cross driver that we probably should have mentioned are prescription drugs. That is driving everything. It's driving hospital costs, it's driving insurance premiums, and it's also driving some of us nuts, because if you don't know the cost of something before you go to the drugstore and the pharmacist doesn't tell you that you can get it cheaper somewhere else, then you're stuck. But that's a pretty discrete issue we might be able to talk with some of the pharmacy folks about.
Yeah, one thing I only discovered recently, we had passed a law quite a while ago that you have to be told the actual cost as well as your copay on the slip. And they do that, but it turns out that quote, actual cost is the actual cost to your insurer, which is a negotiated cost. It's not the actual cost of the drug, which can be massively higher. So.
Exactly. And then if you go to one pharmacy, it costs more than another one regardless of your insurance coverage. Maybe there's some communication that should be going on there.
Ask a question, maybe that help guide us to the next step. So based on everything we've discussed and our charge, and thinking to Representative Donahue's thoughts that, 2, 3, and 5 might be the next meeting. Is our intent to, I see a couple of these, our intent to be, okay, let's determine who we need to have witnesses to address 2, 3, and 5 and get a data dump on us. Maybe have them also come with some recommendations. And then narrow down our focus in the third meeting. Or do we narrow our focus now and ask for specifics at the next meeting? So I look at this, there's obviously more areas that we can move forward. Do we go broad and then focus, or do we focus and then focus some more?
Okay, restate your question. So you're suggesting that A, we get a data dump, 2, 3, and 5, or
we decide what we want to focus to be, and then get the data for those specific items. So go broad and focus, or focus at the start.
well, we can try to do that today. We can try to get the focus for, I like Ann's idea actually of the 2, 3, 5. So we can try to dive into those a little bit, maybe with Nolan's help, Jen's help. Otherwise, if we can't do that, then it's going to have to be the data dump, as you call it. Yeah.
And I would say from my perspective, I prefer the data dump per se, to start really broad. And maybe our next meeting is a full packed day of just witnesses and information and asking questions, and definitely NCSL would be great. Because I think if we, for me personally, if we try and focus now, we might be missing something we don't know about yet. There's so
Or
much that-
choosing a focus that actually is not something
Is
we
not-
can impact significantly.
Right, exactly, exactly.
Yeah, I would, I appreciate that thought. Because, and there's I will also know from my own process, I feel like we sometimes do better, I do better if I can look at broad information and have a chance to reflect further, rather than trying to preemptively identify specific focus at too early a point. And I think that we could take that direction of looking at perhaps 2, 3, and 5, and just that's been laid out there. And also identify some witnesses and also if in fact we have the good fortune of having a consultant available to us prior to that meeting, ask for their assistance as well in looking at that information that would help, that would give us more information about those pieces of our charge. And then allow us to take that and refine it and say, now let's be more specific. We can't do everything. These are some areas that around those parts of our charge that we can do.
Oh, good. I like that idea a lot. I think that was a good suggestion from Representative Donahue and now modified. Yep. I think that makes a lot of sense. And I think rather than trying to narrow down what we're asking for, I think having all of it in front of us is a good idea.
I mean, not to sort of contradict that, but I find it hard unless discussion of disparities are embedded in every conversation to wait until the very end and say, oh yeah, but you're leaving this population out who doesn't have access to transportation. This is their real driver of their costs at this age or because of their race or ethnicity. So I'm hoping all of our witnesses are prepared to share the disparities embedded in each of those data points.
Well,
I think that's key to when, in the perspective of gathering everything we know in order to prioritize and brainstorm on where we act. You're absolutely right. That has to be the critical part, or we won't know what we need to prioritize.
And I think one of the main questions that has to be answered by every witness is who is impacted by what you are telling us and how are they impacted? And then to your point, transportation, what other avenues are we not looking at because we're just looking at healthcare? But yeah, absolutely.
and it doesn't mean that we're saving it to the end.
Right.
Exactly.
What it
That's all.
means is
Yeah.
we're bringing in
By the way.
Department of Health and others who have the data
Right.
to inform our thinking about what's missing
Mhm.
or what is there. So we can do that as well. We'll just have to see how full. I think it would be great to have that integrated in with the next meeting, whether it can happen the next meeting or the meeting after. Might be actually helpful to have it the meeting after. We'll just
Right.
think about that.
I mean, I tend to fixate on a quarter of Vermonters can't get to a doctor's appointment when they need to. So what do we do with the poverty indicators of that, you know, disability indicators?
Yes, sir.
So Manny, so to sort of start making some of these things actionable, like I'm assuming that you're taking Representative Donahue's and saying, okay, let's look at 2, 3, and 5. We're looking at 2, identify primary drivers and health insurance premiums. Well, to me, that's hearing from the insurers and agree amount carefully, because they're the ones who would do that. Looking at 3, review findings and recommendations from previous studies and analysis. Not to put it back on you, but it seems like that's the homework that you as members need to do. Jen sent you a list and you guys have to review the studies. We gave you, or Jen put together a list of what those studies are. I don't know how we summarize them. I think there's some of the homework that you may have to do individually.
Well, I think the consultants would also help with that.
Agreed, and they will, absolutely, and yes.
But that'll also be critical to kind of look at pretty quickly because it may feed into suggestions even for witnesses for the next meeting. In terms of even okay, this study told us this at this point in time, what, can you shed light on what's happened since?
Yeah.
So I think that, and that one, yes, the consultant will help us with that, but I think before the next meeting, we each need to take a deep dive into those studies.
Oh, yeah.
I mean, if you want to identify the ones you're most interested in, fine. But I think go through those studies and then bring in your questions, or B, the things we should be considering about those studies. And if you need any help at all in understanding or interpreting those studies, I think that's something that you can reach out to Jen or Nolan about. Does it make sense to do that?
Yeah, happy
You
to help
guys?
in any way you need.
Okay.
Yeah, we may end up needing to connect you with the actual authors of the report.
Sure.
So we start with this.
Yeah.
Go ahead.
Would it be fair to say that the older the report gets, it's still relevant because there hasn't been an update to that information? I mean, I'm looking at 2009 and thinking, am I reading that report? Does that help me right now?
Well,
I think it depends. Some of it may be useful as either the only snapshot in time that we have on that particular topic, or in order to show changes over time.
Okay.
But some of the more recent ones, particularly around things like demographic data or actual costs of insurance or other things, maybe the older stuff may be less relevant because of the increasing costs over time.
But that also would be an area of looking at disparities. And so wanting to know an update on that. That could be a recommendation.
And all the actual clickable links are now on our page. Like this is on our page, so we can click these links.
Right, this
Okay.
is Charlene has posted this under my name on today's date, and you can go into it and click the link. And in some cases, if it says things like link to reports page, there might be a few different reports included on that page. So that's a good suggestion that instead of just sticking all the separate links on here, which I'd originally done, it's a little overwhelming, you can go there.
So for me, I'm looking at number 5, and for me to analyze long-term trends and out-of-pocket costs, and for a small group, an individual and large group, looking at those. And in the federal government, we passed something on our health insurance, but that'll be part of the trends. But for me, it would be interesting to know the distinction between primary care costs versus other out-of-pocket expenditures. Because, but for me, primary care is the entryway into the system, and it will overall, over time, as prevention, lower costs and increase access. So if there's a way to get at a distinction between primary care and prevention in number 5, as compared with other out-of-pocket, including, long-term care. I guess long-term care should be considered prevention too.
Yeah, I mean, that's often left out of the discussion.
Yeah,
I think the other important thing here is to get that analysis in the different categories, because along with identifying which ones we can impact and which we can't. So, we get information about really high out-of-pocket costs in an ERISA group that we can't do anything
We can't
about unless
control
it's all
that.
state funds, that those distinctions are important as we get that information.
I also don't know, and I have to talk to the Human Care Board about what's available in D cares. Like, we can look at out-of-pocket spending, but I don't know if you can, how hard or easy it is to take out-of-pocket spending and put it into those individual buckets.
yes,
I don't know.
I don't know.
If that can be done, or, I mean, it probably can be, but that's well beyond my skill set.
Really, that gets right down into the individual type of premium
Plans.
type of program that you're in, right?
But wouldn't, potentially DFR would have, what some of those approved rates are for different plans in terms of what the out-of-pocket.
Well, there's difference. There's what the rates are for what a plan offers and what people are paying.
No, I understand, but if as a piece of getting a sense of the trend, if the majority of just randomly, the majority of small group plans used to be a $10 copay to see primary care doc, and now it's 25. Things like that,
So
I think
that's
they
gonna
would
be
have, right?
probably Diva, because those would all be Vermont Health Connect plans.
But we're also looking for the same information for large group,
Right.
so that would
Right,
be
so that I
DFR.
think maybe more DFR.
Yeah.
And I think you may need to ask multiple sources. You may want to ask DFR and DVET and the carriers
Right,
to tell you what they've been proposing, carriers can tell you what they've been proposing and why. And
I was gonna
also-
flip the question.
Sure.
I would say, how much would it cost to offset out-of-pocket expenses for? How much would it cost to provide universal primary care? And I know we did that a couple of years ago, but insurance companies could say, yeah, it'll cost this much overall. Diva could say it'll cost this much overall. It would be like to know. Can we do that?
Well, so repeat that question because I was still processing the last piece.
I'm sorry.
So the question was whether we could ask the DFR and DVET and carriers to say what it would cost for the state to subsidize or to pick up, I think, the difference or the out-of-pocket piece for something like primary care, that idea of universal primary care. Do you think you have studies on that? I mean, they're a few years old, but they, as you may remember, that the first threshold question is agreeing on what primary care is and isn't.
Right,
It's a huge list.
just update that.
Right, so I think and some of that work has been done at least in service of that exercise and coming back with the estimates on the cost of universal primary care.
but you're right, it's the flip side of what are the increases in cost people have been experiencing in
Yes.
these different categories versus
Yes,
if we wanted to, what would it cost us to,
yes.
in whole or in part even,
And-
know,
and-
cut
Right,
in half the
Yeah, I think that's a great question. It's a very heavy lift. And the other thing, and the other point I would make too is there's two differences to go back to what Representative Donahue did where I was processing. There's what the carriers have been offering in terms of increased cost sharing for similar plans over the years. And what people are actually paying in rather. And it's not always apples to apples because they might shift their out of pocket in one area and move it to another area. Like
Yes.
so it's hard to gauge, if we get to the end, they're trying to fit within an actual range. So they might say, okay, well, the copays went up on X, but they went down on Y. And so how do you measure that, especially with more utilization in one area than the other?
Well, the even bigger interplay is, of course, with the deductible, because if you've got randomly $1,000 deductible, you're not getting any, it's not.
Well, what makes it even harder is the HSA's HRAs. We don't have data on that. So a lot of employers are offering these plans where they're saying, okay, well, we're going to get a $2,000 deductible plan, but we're going to cover $1,500 of that. We don't know if the employer, if the out of pocket, if it's the employer paying it or the individual paying it. And that makes it harder to gauge.
but even if the employer is covering it, then that's the next discussion. So how much is it, first of all? And then if maybe there's a way we could interview groups of employers, so, or professional groups like BBSR. Or there may be, and there are others. And from their perspective, what coverage do employers give overall? Kind of an average.
I can't speak. You have to ask them.
Yeah, we'd have to ask that. We don't. Go ahead. I'm looking at the screen.
Well, I just, as someone who isn't on a healthcare committee, I keep going back to Representative Houghton's question about who are we impacting and how granular we can get. Can we know that this income level is the most distressed or underinsured? Can we know this age group is experiencing the most, cost drivers? Can we know you have diabetes or mental health issues, your prescriptions cost the most. I mean, how granular can we understand who is the most distressed and underinsured?
So we have gotten some data on the past, I think from the Healthcare Advocates Office has some good information on that. So there are some sources of that. I don't know the level of detail, but you know, where some of those cliffs are, which of course, as was pointed out, have changed, at least in the short term. We don't know if it'll be extended by the addition of subsidies. So
And so the question is, we're currently subsidizing, but are we subsidizing sufficiently? Are the needs being met? And so that is a question, that is the question we're asking, but we're trying to go and look at different segments of the healthcare system to understand that. Yeah, we have to keep that in mind consistently.
Something else I think we need to keep in mind is we have accessibility and we have affordability. And for different groups, one is more important than the other. You know, we might say, there might be one group that says, well, I can afford it, but I can't get to it. There's no accessibility, or vice versa. So we link the two together, but when you look at how we're impacting populations, I think it's also would be interesting to keep in our minds, okay, which one is it for that population?
One of the problems we have too, we have lots of different data, but they don't always link. So for instance, when we're doing basic budget last year, I was looking at some out-of-pocket data and I found that the percentage of people with zero out-of-pocket was pretty high. There was a lot of people who didn't have claims, and the percentage of people with high out-of-pocket wasn't that high. However, the people, to them, that's, even though the percentage of the population that has very high out-of-pocket costs was small, for those people, it's a very big deal. But what we don't know is, we can't say is, okay, who are those people? What are the disparities within that population? Why? And the people who didn't have out-of-pocket, we can't say, did they not seek services because of their high deductible? Well, we can't figure that out. We just look at one snapshot. We can't take that snapshot and insert somewhere else. So that's part of.
yeah, to Lori's point, I mean, I recall way back when there was an issue about dialysis treatment being available in the Northeast Kingdom. And those folks, it was not a cost, it was an access, having to spend a whole day. And yet establishing, I mean, that treatment is considered, it's the most expensive on the cost benefit ratio that you can get. So establishing a dialysis center in the Northeast Kingdom had a huge healthcare system cost. So those are the kind of struggles that we're always trying to balance.
Reminds me of our hub and spoke and making treatment accessible across the state, rather than having people drive 3 hours one way, twice a day, two ways, twice a day.
Which is a great way of not raising costs and yet making it accessible. And that's a great model for that. Versus when you have to do a trade-off where it might impact affordability for some people by raising system costs while it's making it more accessible for people. So yeah, I think the hub and spoke is a super example.
So I'm thinking that we've kind of gotten to a place where we might want to let this settle for a little bit. And unless you have a different idea, Bill?
No, I'm actually thinking something similar, that I think I think Nolan, some of what you were saying, how to make it granular in terms of, or granular is very actionable in terms of where would we turn for information on these areas. And you were talking about for number 2, Green Mountain Care Board, and I think on number
3 falls squarely on all of our shoulders and our consultant.
And number 5, talk about DFR carriers.
And we also talked about the Department of Health. in terms of,
Yep.
Disparity. information.
It also might be helpful to hear from the Green Mountain Care Board, like what can they get you through BQ?
Right.
Have some
For
necessary
features,
Yes.
yeah, right.
and make a request to them directly right there.
And we talked about, you raised DIVA in
Well,
terms of
yes.
the impact of.
So I'm thinking of two other things. I'm thinking in terms of how we might structure a next meeting. In terms of information that informs us as we then become more focused. I would come back to, I would like to hear from Eva about the federal influx or the impact of federal dollars around premiums. And to get as good a sense as we can from them about what that impact has been, who it's impacted, et cetera, the amount. And I think it would be useful, maybe two other things come to mind. One is, this is kind of like setting the table, if you will. One is to perhaps hear at some level from the Department of Health about the data they do have available around health disparities in Vermont. Maybe have some federal or some national data, but we really are interested in Vermont and we know that's real.
I don't think that should take a lot of time, and I think it would, I mean, at least to get an introduction to what they have.
Yeah.
But we've done that,
Yeah,
and
right.
I think we could do that during the next meeting, relatively,
Yeah,
in a
well,
very
that's
short period of time.
I agree.
Yeah, okay.
That's what I'm
I was
suggesting.
hoping. Good,
Yeah.
sorry, to interrupt you.
Another thought there.
Keep going.
Well, I think
No, you got there. It all
yeah,
makes
so
sense.
witnesses around the three different areas. Hear from DIVA, hear from the Department of Health around disparities.
And hopefully by that time, we'll have a sense of the consultant and the work that they can do. And we'll also connect again with NCSL and see if they have any thoughts about what other states are doing. And I guess there are a couple of things I think we should consider. I don't know that we need to have a long discussion. We have 5 meetings. We have been encouraged by some. We got a letter. I think we all received a letter from the Workers Center and a number of groups. A very thoughtful letter. And we can put that on our webpage for folks to access and see. But their request was that we go around the state and have public hearings. And we have 5 meetings. My hope is that the Healthcare Advocates Office can provide us with some of the information that we would have gotten having gone around the state. I just know from my experience that in our committees and in our local districts, we hear every day and we have emails. I don't know that we have the time. I'd love to go out and hear from the public, and I'm hoping that we will hear from folks who would like to come in and testify or participate in the meeting to the extent that their comments will be focused and helpful to our work. But I don't at this point anticipate a public hearing unless things change. That's my thinking on that. And it's a rock and a hard place.
Go back just to number 3.
Sure.
Sorry.
No, that's okay, but I'm looking for some comment from folks on the task force. If you believe that we should have a public hearing, I'd like to kind of hear that.
Well, so there was I think it was the Workers Center who did at the end of June, was it? They did a
Yep.
forum.
I was
think
there.
Some of us attended.
Yes, I attended as well.
Yeah.
I did.
So
yeah.
that was
I
really
watched.
helpful
Yeah, we're all
to
there.
hear from them. I'm hoping also the healthcare advocate can provide information, because I'm just not sure that we do that.
Okay, and we'll see where we get, we'll see what happens. Number 3,
Sorry, so there's two, as we're talking about witnesses, I feel like there's two groups we're leaving out that might be beneficial to hear from. So as most of us know, I know, Michelle, I'm sorry, I'm going first name. The healthcare committee. But there was a fabulous group of stakeholders that helped us over the past 18 months. And.
oh yes, they were excellent.
Yeah.
The
and
Healthcare Alliance.
The Alliance.
I call them the Star Wars Alliance.
There you go.
Yeah,
when we talk about sustainability of the system and primary care providers, I think it might be important to, if they're not too busy, to hear from them as well as what, they've had 18 months now. They had it before and before COVID and during COVID, and what are some recommendations they might offer specific to that population, and also what, especially long-term care. And then the second group, and you brought it up, Senator Lyons, was businesses and what are they experiencing? I don't know how we fit it in or where we fit it in, but do they have recommendations as well?
So,
We've just changed actually the relationship between the small group
Right.
and the individual market. So
Right.
that's something which is newly.
But
that's
maybe
what I
temporarily. It's
mentioned
temporary.
earlier, right,
Yeah.
exactly.
Yeah.
Well, so what we'll have to do, I think Bill and I will have to sort out what's possible in the next meeting. And then all the groups and folks that you've raised might be something to take into the third meeting. We'll just see what the time frame looks like, what we need to do all of that.
Throwing it out there as ideas.
Right, and then there is another little elephant in the room. One is we do need to go through the Act 48 principles, and we'll do that. We
Right
have
after
5
lunch.
minutes. We could do that today and just go over into the lunch hour a bit. Unless you can't do that.
I can go over a little bit and then I need to
Okay, well, to the extent
back up to
possible.
Bryson and then.
The other thing is that there is a strong opinion by some that we should be moving toward single payer. And I don't know, I don't want to get into that discussion necessarily, but I think we each have a goal of providing affordable, accessible healthcare to all Vermonters, whether it's done through single payer or another way. And there might be ways that we can begin the process of allowing for access that's affordable. And that's why I always go to prevention and primary care. I think that's a good place to begin to look, whether it is fully publicly supported or whether it is a public-private relationship. But I don't think we throw anything out, but we don't have one idea. I think our goal is to try to put together as much as we can that will work to help people.
Well, I'll just be clear. While I support us getting healthcare for all Vermonters, it's affordable and accessible, I'm very interested in what we can achieve. That we can actually take steps that impact Vermonters. Now, that we can do as Vermont and within the resources that are available to us. So, well, I think that's part of the frame of the project as well. So I think we should be reminded, Jen, as Jen just did, that she's available to us by Zoom this afternoon, not in the room. I think that's correct. Is that right? So
Do you want to wait and do that?
we could go through the Act 48 principles by Zoom with Jen.
Sure. Is
Sure,
that,
and I can put them up. for you.
does that work for you? Okay, let's do that. That's good.
Maybe depending on our time this afternoon with the Healthcare Advocates Office, we can
Yeah, we'll have time.
combine that.
Yeah, I think we'll have time.
And then
We'll have half an hour.
I think one of my big questions is how to take the principles and align it with the report to understand what are our ways of measuring how we're achieving. Because I get the principles, like I can read them and be like, yep, I was there, remember, but where do I find our measurement of our?
Where do we
of
stand
our-
on them?
Yeah.
Well, that may come back to what is affordable, what's accessible.
Yeah.
Right,
Kind of some
right,
of the
yeah.
definitional issues.
Yeah.
And we may find that we can measure them, and we may find that there's some challenges to measure,
Right.
but I think it's an important question.
It is, and it does also get back to the regulatory system and which HROC is looking at, because Green Mountain Care Board was created for a single payer
Mhm.
model, and it is now operating under something quite different. So we aren't going to go in the regulatory direction, but it's a good question. Senator Westman had an emergency with his rentals, and so he was able to be here, but he's going to try and get here this afternoon. And so let's see, I'm going to ask Lori and Ann to bring him up to date on exact number.
Oh, the House,
Good.
the House always looks forward to educating senators.
I think maybe
Okay.
we're approaching the time to go off.
We're off, we could go off Zoom, I guess, off YouTube for now, and we'll take our lunch break.
Then we'll be hearing from the
Okay.
healthcare advocate.
Thank you all. That's been really good. It's been very, 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 very good.
Are we off?